Welcome to lecture for psychopathology. We'll be talking this time about the anxiety disorder. So starting off, let's begin with a discussion of some of the key concepts and terms related to all of the anxiety disorders. Which are really, these things we'll talk about are really all aspects, arguably, of the same construct. We'll look at fear, anxiety, worry, and panic. And each one plays a different role in a person's life, depending on what kind of anxiety disorder we're talking about. Let's talk about fear first, right? It's an emotional response to real or perceived immediate danger. Right? So something scary is there, and you have an emotional reaction to it. Or, again, real or perceived. So either you're walking on through the woods, as you're prone to do, and a bear jumps out of the woods. And it's a danger. It could hurt you, and you have an emotional response to that bear. That's a real immediate danger, right? Or you're walking through the woods, as you're prone to do, and you hear a rustling in the bushes. You think, oh, there's a bear there. And you perceive there's danger, and you have an emotional reaction to that perception, right? And your perception and reality don't necessarily have to agree for you to have a legitimate emotional response. And in this case, the emotional response is fear. And when we talk about an emotional response, at face value, at first look, that's, oh yeah, I know what an emotional response is. That's simple. But emotional responses, if you study them more closely, can be fairly complex. What precisely do you mean by the emotional response? Is it just, oh, I feel scared? Yeah, that's part of it. There's kind of a subjective component to emotional responses, but there's also a physiological component, right? With fear, we often talk about increases in heart rate, release of adrenaline, shortness of breath, perhaps. Your pupils dilate, dilate to let in more light so you can see the thing that's scary, right? And then you also have a kind of a behavioral response. That may all that what you do when you're afraid. Clutch the person next to you, or crash down low, whatever it is. All those things together, so the subjective, the physiological, and the behavioral, are all part of this emotional response. With the idea being that when there's something dangerous, this complex emotional response is fear, which can be distinguished from anxiety, which is also an emotional reaction, but it's a more diffuse emotional reaction that's associated with the anticipation of future problems, or associated with ruminating, thinking about past problems. So again, you have complex emotional response, but it's not as strong a feeling as fear. So we also have less of well, in the short term, less of a physiological reaction. But again, it's diffuse, kind of diluted, right? So you think about you have a certain amount of fear in a 5-minute window, and think about how much your heart rate's going to go up and how much cortisol is released throughout your body, and then stretch that out across a longer span of time. Right? So maybe the same amount of reaction overall, maybe even more, but it's spread out more over time. Right? So less intense, more spread out. And again, it's either worrying about something, this emotional reaction to things that could happen, or again, when you're thinking about past problems that aren't yet resolved, having an emotional reaction to that. And notice I started to use the word worry there, and that's because worry is actually a component of anxiety. And so we often use those words interchangeably. But worry really refers to just the cognitive component of anxiety. Right? That emotional reaction includes what you think, your subjective reaction, physiological, all this stuff. But again, there's that thinking about stuff that leads to, is associated with emotional reaction. And the thinking part about things that make you anxious is worry. Right? And often worry is used to try to deal with the emotional reaction, but can also cause the emotional reaction. So you might worry to deal with the anxiety. I'm feeling anxious, so I'm going to worry. I want to think about it some more. But thinking about it more often causes more anxiety. So they're definitely interwoven. And then panic, really distinguished from fear, is just the amount in terms of time and amount. It's sudden, overwhelming fear. So if you see the bear and you think, ooh, that's scary, you're experiencing fear, your heart rate goes up a little bit. If you see the bear and you really get scared suddenly, and it's not, I'm getting kind of scared, like you're watching a scary movie and you're getting more and more frightened, right? That's fear building. Panic is when something hits you at once and boom, your heart rate goes from resting to 110 beats a minute, and you get the huge rush of adrenaline, and you're short of breath, and maybe your chest hurts, and your muscles are tight, and you're ready for that fight or flight. Right? That's when we have panic. So panic is just more of fear, and suddenly it's kind of an acceleration to a heightened state of fear. Okay. So now that we kind of talked about these different components of fear and anxiety that are related to anxiety disorders, take a minute to think about what your life would be like if you no longer experienced them. No fear, no anxiety, and no worry. How would your life be different? So most of you, when you think about this, you're probably thinking of, initially, some good things. Like, oh, geez, if I didn't worry about this, I could do this. If I wasn't afraid of doing this, I could accomplish this thing. But the more you think about it, you start thinking, well, but if I wasn't afraid of this, this might happen. Right? So, when we talk about these things, they are sometimes adaptive responses. Sometimes they're good for us, right? At certain levels, it's adaptive to be afraid, even to worry, right? If a bear comes out of the woods at you and you're not afraid and you go, hey bear, what's going on? You go to shake its hand, it might very well rip your arm off, right? If it's a hungry bear and doesn't like people, it might do that. But your fear is there to keep you alive. People who were afraid, kind of going back across our, reaching into the reaches of time, back to your ancestors, the ancestors of yours that were afraid of bears lived. The ones that had no fear of bears were eaten by bears, right? So fear was a good thing then. It's still a good thing now, right? Well, you get that kind of, oh, I get this prickly sense in the back of my neck, and that situation doesn't look quite right. I'm going to get away from it. You know, sometimes that's good, and you're getting away from a bad situation, right? Your emotional responses are there as signals to tell you about the world. So, and a certain amount of fear is good for you. Even a certain amount of panic might be good for you. It's like, this isn't just be afraid. This is get your ass in gear and go. You have to go now. Right? So in certain situations, fear, panic, and worry are appropriate. They're adaptive. And also, they're adaptive when they're not uncontrollable, when they can be controlled. So when you can do something about the thing that's making you afraid or worried or anxious, and the feeling can go away. So it's adaptive. It's a signal to you that you can use that information to make some change, and then the feeling goes away. But kind of your first response, oh, it'd be nice if they were gone. These things can also be pathological responses sometimes, at certain levels, in certain situations, and when they can't be controlled. Right? So if you are too afraid to where you're immobile, that's going to be bad for you. Being too anxious is also not good for you, right? If it keeps you from, if it stops, instead of being a signal to do something, it just becomes something that distracts you and keeps you from doing anything. Well, then you're not going to avoid whatever danger you were worrying about. You're still going to get eaten by the bear. Not going to have enough food stored for the winter if you don't worry about it, right? So you have to have some anxiety, some fear. And this kind of, one thing I often think about is that kind of the relationship between performance and anxiety. And that curvilinear relationship, right, where if you have no anxiety on many things, your performance will be fairly low. If you're not worried at all about how you're going to do on your next test, you probably won't do very well, because if you're not worried about it at all, you're not worried about it, it's fine. You don't study, then you do poorly. If you worry a little bit, at first, the more you worry, the more you study, right? So there's kind of this positive linear relationship. But there's some point whenever, okay, I've worried to the point where I studied all I can study. If I worry beyond that, I keep going, all of a sudden the curve turns, stops being a positive linear relationship, goes to a negative linear relationship, to where, okay, now the more and more and more I worry, the less what I'm going to do, because it's going to keep me from studying, because I'm so worried that maybe I don't study, or I get drunk to go distract myself, whatever. Right? So again, certain levels, certain situations, and when they can be controlled, we can do something about it. Beyond control in terms of being able to do something about the things you're afraid of or anxious about, how much control should you have over your anxiety? So how much, whenever, let's say you're not able to, there's something that you're worried about that you have no control over. Right? Maybe you're waiting to find out if you're accepted into some program or for a job. And you've done everything you can up to that point to get the job or into the school or whatever. And now you're just waiting back to hear. Right? So there's nothing you can do. The anxiety signal saying, oh, be worried about this, but there's nothing you can do about it anymore. All you can do is wait. How much should you be able to control your anxiety until you hear from whatever the result is? There's not an easy answer to that, and I think it differs across individuals. But I think what's interesting for counselors, and what would be more important, is that people seem to differ in the degree to which they need or want to be able to control that anxiety. Some people seem better able to tolerate having anxiety. And people that have a real high need to control anxiety and need to not experience it for things that they can't control, that's when anxiety can sometimes become problematic. Right? So if you have a high need to control anxiety, which is usually associated with a high level of aversion to anxiety, that might be a risk factor for developing pathological patterns of anxiety, possibly even anxiety disorders. How can you experience anxiety pathologically? Lots of ways. And the major disorders we talk about are specific phobia, social phobia, panic disorder, generalized anxiety disorder, which I'll often refer to as GAD, obsessive compulsive disorder, OCD, post-traumatic stress disorder, PTSD, and its temporal cousin, acute stress disorder, and finally adjustment disorder with anxiety. So we'll talk about each of these. Okay, starting off looking at specific phobia, just kind of go over the DSM criteria briefly, make sure that makes sense to you. First criteria, a marked and persistent fear that is excessive or unreasonable and is cued by the presence or anticipation of a specific object or situation. Okay. So what does marked and persistent mean? How can fear be marked and persistent? Well, marked means, noticeable a lot. So it's not just, I get a little creeped out by that. I see a spider, I go, ooh, scary. It's not a marked fear. Marked fear is, oh, spider. And persistent, it is, hopefully this is obvious to you, it lasts over time. So you weren't scared of something once, something jumped at you, ooh, scared me, but consistently, every time you see that thing, or anticipate seeing that thing, you have a fear reaction, that emotional reaction. But even then, if you have a marked and persistent fear, it's not yet rise to the level of meeting this criteria. The fear, so the emotional response, has to be excessive or unreasonable. Okay? So what's a reasonable amount of fear? It depends on your culture and a lot of other variables, right? How afraid should you be of guns? Well, it depends on where you grow up. Right? How afraid should you be of snakes? Depends on where you grow up. And some things, it seems more debatable, things that could clearly kill you, like snakes, you probably have to have a higher level of fear of those things for it to reach this kind of idea of being unreasonable, because there's a certain amount of reasonable fear of snakes that's higher than a reasonable amount of fear of stuffed animals. Right? So depending on what the object or situation is, what is excessive and reasonable might differ. Right? So there's some subjectivity here. Okay. So it's excessive or unreasonable, and who decides if it's excessive or unreasonable? Generally, you do as the clinician. That's part of your clinical judgment. And then this excessive unreasonable fear is cued by the presence or anticipation of an object or situation. Okay, so either the thing is really there, or you think it might be there. There's something that makes you think, oh, I hear a dog barking around the corner is a dog, and you have this emotional reaction. Right? And you don't have to be right that there's a dog there. You just anticipate it. You think it's going to be there. And that's enough to cause emotional reaction when we're talking about a phobia. And again, it can be a thing, an object, or can be a situation, like flying. Okay. Criterion B, exposure to the phobic stimulus. And phobic stimulus is the fancy way of saying the thing that scares you. Almost always provokes an anxiety response. And in kids, the fear may be expressed via crying, tantrums, freezing, or clinging. So they don't have to say that they're afraid, and that's put in there because there's a recognition that kids might not be able to verbalize their emotions clearly. But if they do exhibit these behaviors, which we think of as exhibiting ways of exhibiting fear, then that counts for the criteria. So almost always you have this anxiety response. In here, the DSM mixes words because again, it probably should be more of provokes a fear response than an anxiety response. But I think they're using anxiety in the more general term. The person recognizes the fear is excessive or unreasonable, which again you don't have to have for kids. Kids don't have to know that it's not okay to be that afraid. Again, the idea here being that they have they're less well cognitively equipped to make to know what's reasonable, what's unreasonable. So you can still diagnose them even if they don't think, oh no, of course I should be that scared of my teddy bear. It's really creepy and scary. Okay, fine. Still could be a phobia. But why for adults do we say, well, you have to recognize that's excessive and unreasonable? And one says, no, really, planes are dangerous. If you fly in them, it could fall to the ground and kill you. That's a scary thing. People who aren't afraid of it, they're the ones that are crazy. Why do we say that they have to know it's excessive and reasonable? Two reasons. One, the person might be delusional or psychotic, right? So if they think, that the teddy bear is frightening, and they have a phobic reaction every time they see the teddy bear, and they don't think it's unreasonable because they think the teddy bear is possessed by the devil. Okay, when this isn't a phobia, it's part of their psychosis or their delusion. And then the other thing is, supposing they're not delusional or psychotic, it might be kind of a thing with flying where somebody really rationally believes that something is dangerous. Then it's kind of that where some subjectivity comes in, and okay, well then it's not a phobia if you don't think it's a phobia. If you think you're supposed to be afraid of this and it really is a scary thing, then we're not going to label you. So the person it's almost like the person has to have a problem with being afraid to meet criteria. Rest of the criteria, the phobic situation or situations are avoided or endured with intense distress. Okay. So they'll do whatever they can not to, if they're afraid of dogs, whatever they can to not be around dogs. But sometimes they can't for whatever reason. Their roommate gets a dog, so they endure it, but it still bothers them. The avoidance, anxious anticipation, or distress interferes with functioning, or there's a marked distress about having the phobia. So again, this is getting a little redundant with what we just talked about, how they have to recognize it's unreasonable or excessive. So it bothers them, or even if it doesn't bother them, yeah, I know this is unreasonable, but I don't want to change. I'm scared of flying. I know other people aren't, and I probably shouldn't be, but I don't care. Okay, well, if that's the case, they don't meet criteria unless not flying is going to interfere with their functioning. So this is where the focus of their fear may determine whether or not they have a phobia. Right? So if you're afraid of flying and you have a job that requires a lot of travel, and so now it's harder to do your job, it's more inconvenient, maybe you're more likely to get fired because you're not flying, well, now your avoidance is interfering with your function. And now it's a phobia. If you don't have any reason to fly anywhere, and you're just as afraid of flying as this other person who does need to fly, they have a phobia, and you don't. Right? So you may be genetically identical, you have the same predisposing factors, all this stuff, but one gets a label, one doesn't, because of the life setting. Right? Which again should remind you that applying these labels is somewhat subjective. Okay. Okay. The next one, if the individual is less than 18 years old, so for a child or a young adolescent, the duration of this kind of phobic reactions is at least 6 months. Why is that there? Why do you have this thing? Well, for kids, yes, 6 months. Everybody else, no. Just, if you have it, you have it. Well, in kids, some transient fears are pretty normative in childhood, right? You have separation anxiety, I think we've talked about. You've got kids, which is common in toddlers. Kids 2 to 6 often experience fears of the dark, animals, monsters. When kids start school, they may have a fear of school. Older kids, kind of preteens, may have a fear of getting hurt, especially if somebody in their family is injured in a kind of a significant way. But these again are normative, developmentally appropriate, and transient fears. Transient meaning they go away after a little while. And the idea here is that, well, if they have a fear and it goes away after 4 or 5 months, it wasn't phobia, that was just a normal, developmentally appropriate transient fear. But if it persists for more than 6 months where you're having these reactions, okay, and then maybe it is beyond just the typical transient fear, maybe it is a phobia. We also throw in symptoms are not better accounted for by another disorder. And this is just where we don't want to over-label somebody. So if another label better explains their behavior, we don't give them 2 labels. Right? So somebody that has anorexia nervosa, which involves a fear of being fat or a fear of food. Right? So they may have really strong reactions if they think they're getting fat, or if they even strong phobic reactions to food, and they'll avoid food, they'll try to avoid being fat. Well, that's not anorexia nervosa and a specific phobia, it's just anorexia. Right? That disorder explains it by itself. Hypochondriasis, another one, which is a fear of having a disease, not the fear of getting it. If you're afraid of germs, that might be specific phobia, but if you're afraid that you have a disease and you ruminate and obsess about that, then that's hypochondriasis, which is a different thing. And again, like I said, if you're afraid of germs in general, and if you're a germaphobe, then it might be specific phobia, unless there are rituals involved with your germophobia, like if you wash your hands ritualistically to deal with the anxiety caused by being afraid of germs, then it's obsessive compulsive disorder because you have compulsions. And you don't get OCD plus specific phobia if the OCD explains what you're afraid of. And then also PTSD, right? People with PTSD might be thought of as having phobias related to whatever caused that trauma or to certain triggers. Like every time somebody who was was in a car crash, if they go down a certain street and they have this phobic reaction, so here's this phobic stimulus, is this certain intersection, and when they get near the intersection they have an emotional reaction. Okay, that sounds like phobia. But no, not if they meet criteria for PTSD, then that emotional reaction is explained by the PTSD, and you don't give them the specific phobia on top of that. Okay. Last thing about the DSM with specific phobia, you typically specify the type. If it's blood injection injury, animal, natural environment, situational, or other. And originally, when they had these kind of categories, they broke them up, thinking, okay, well, people who have natural environment phobias, fear of heights, for example, might be different than people who have animal phobias, fear of dogs. And where everybody that has fear of animals will be similar, fear of dogs, fear of snakes, fear of birds, whatever. Okay, all you people will be similar, and you will all be different people who have fear of heights, fear of water, fear of whatever, environmental things. And they thought that would be true, but the research hasn't really supported it. They don't seem to be different in terms of how they respond to treatment, the course of the phobia if left untreated, level of genetic contribution, and all the things you kind of look for to say, oh, there are different types of things. It seems to be the same disorder, just with a different focus. With the one exception possibly being blood injection injury, it does seem to differ from the others because there is a different physiological reaction. People who have a blood injection injury, people who are afraid of needles. For most people, when they're presented with the phobic stimulus, a heart rate increases. People with a blood injection injury, when presented with the phobic stimulus, often their heart rate decreases, right? Which is different than the others. And there seems to be more familial aggregation, so it tends to run in families more than other phobias. So being phobic may run in families, but mom may have animal phobia and then the kid has natural environment phobia. But if mom has a blood injection injury type phobia, then kid, more likely if they have a phobia, it probably is going to be that blood injection injury. So there seems to be maybe a stronger genetic component to that particular thing, but not so much to the other subtypes. Okay, so let's talk about the experience of specific phobia. One thing to keep in mind is that the focus of fears sometimes change across the lifespan. They change, they shift in predictable ways, especially when we see developmental changes. Right? We see, fear of separation from caregiver at one point. That doesn't even occur until a child is cognitively able to appreciate the absence of a caregiver, right? Not until you have object permanence and you know that they aren't disappeared, but okay, they're gone. Are they coming back? That's when you have separation anxiety. Fear of heights. You have to have motorically developed to the point where you can fall, right? So babies that aren't crawling yet aren't afraid of heights, typically, because they haven't had any kind of chance to fall or move around enough to kind of develop this really depth perception awareness about falling. Fear of school, you can have that until you start school. Fear of social evaluation, you don't see that until people are cognitively aware that others can have thoughts about you, right? That kind of goes back to when we talk about things like theory of mind. Sometimes when kids are very young, they think whatever they see, you see. So not until they're able to appreciate that, people can look at you and not know exactly what you're thinking, what you're doing, and that they may misunderstand you and they may judge you negatively. Not until you can do that, do you really have this fear of social evaluation. And then we talk about kind of epidemiology, onset and prevalence. Specific phobias typically appear first in childhood or adolescence, right? So fairly early on in life. Social phobia, which we'll talk more about in a bit, is typically a bit later, adolescence or adulthood, which again goes to that not until you really start understanding that people might be judging you, do you potentially have a phobia about it. Lifetime prevalence for both specific phobia and social phobia is about 12%. And most people that have one specific phobia have another one. Right? It's rare that you find it where they're afraid of just one thing and nothing else causes a phobic response. They seem to be somehow sensitive to, prone to being scared of things, and that fear can be focused on more than one object or more than one situation, in which case it's a separate phobia, right? As I've already talked about, the level of dysfunction depends on the phobic stimulus. If the thing that you're afraid of isn't something that you're going to face or encounter typically, you're probably not going to have much dysfunction. So plenty of people that have specific phobias don't require treatment because they're able to craft their lives in such a way that they don't need to deal with whatever it is they're afraid of. So if you have a snake phobia, you live in the city, as long as you don't go to the zoo, you're probably good. You don't really need to get over that. If you want to, you can go seek treatment, but it's not going to cause problems in your life. It's not going to cause dysfunction. No worries. As I talked about, most phobic responses involve an increased heart rate, with the one exception being blood injection injury phobia, where you actually have a brief acceleration, but it's followed by deceleration. Um, so there's that physiological response. Panic attacks may occur related to phobia. So when you encounter the phobic stimulus, or you anticipate seeing or experiencing a phobic stimulus, a person might have a panic attack. Just because they have a panic attack doesn't mean they have panic disorder. Right? Because if you have a panic attack in response to a phobic stimulus, that is a cued panic attack. The panic attack was cued by the phobic stimulus. Phobic stimulus caused, to some degree, at least cued this panic attack. If it happens, it's not specific phobia and panic attack or panic disorder. It's just specific phobia. And you might note on there, with panic attacks. You don't have to. So may involve panic attacks. Just depends on the level of fear they have when they encounter their phobic stimulus. Also, hypervigilance for the phobic stimulus or stimuli often present. So this just means that people who have strict phobia tend to be wary, kind of watchful. Right? So it's not like they have this fear of dogs and they just forget about it and never worry about dogs for being there. There's always part of their mind that's on the lookout for the potential that scary thing could be around the next corner. Which again, depending on how much hypervigilance you have, that also might be related to more dysfunction. Because if part of your mind, part of your mental energy is being divided off to worry about this thing, well, you have less mental energy to do other stuff, right? It may lead to impairments in concentration and other psychological impairments. Okay, now let's talk about the etiology of phobias. Looking first at the psychological contributions. We think of two things. We think about the acquisition of phobias, how you develop one, and then how they're maintained. And in terms of first acquiring a phobia, first getting a phobia, developing it the first time, it's suspected that for many people, classical conditioning plays a significant role. And remember, classical conditioning is all the stuff that Pavlov studied with the dog and the salivating, right? Where you have an unconditioned stimulus that leads to an unconditioned response, right? Where meat powder makes a dog salivate. And there's no conditioning whatsoever. It's just a kind of reflexive reaction. Present this, you get this response. And then you pair a neutral stimulus, let's say a bell, with a unconditioned stimulus. And if you do that enough times, then you can stop presenting the unconditioned stimulus, just present what used to be the neutral stimulus. And now, if you present what used to call the neutral stimulus, and it gets that what used to call the unconditioned response, so now we ring the bell, and the dog salivates. Now we have a conditioned stimulus and a conditioned response. And the idea being that for some people with phobias, there's stuff that's naturally scary, and something naturally scares someone. And when that happens, it's paired with something that didn't used to scare them, right? So maybe somebody who wasn't afraid of dogs. Dogs are a neutral stimulus, and then they get maybe bitten or attacked by a dog, or they watch a scary movie with werewolves in it, something that scares them, and now that being afraid is paired with the general stimulus of dog, to where now when they see a dog and the dog's not attacking them, so it isn't that unconditioned stimulus response. The dog isn't doing anything. It's not being scary, but they get scared anyway. Now it's become a conditioned stimulus. Right? So that may play a role for some people in the development of phobias. But whether or not that happens may depend in part on their level of anxiety sensitivity, right? Because not all people will acquire phobia if given the same kind of stimulus response experience. So, and let's say we wanted to get really mean and lock somebody in a closet, which is a scary thing, and then we put some spiders in that closet, and maybe they weren't scared of spiders before, but now we lock them in the closet, and that's scary, and there's spiders in there too. Now they associate the spiders with that scared feeling of being in the closet. We let them out. Later we show them spiders and they freak out. Okay, we just made them scared of spiders. That would work with some people. It may not work with everybody. And the reason we might see some differences is because there may be individual differences in the something we call anxiety sensitivity, right? Which is anxiety sensitivity is a fear of anxiety-related sensations, right? When you experience anxiety and fear in general, you have that increased heart rate, your mouth gets a little dry. It feels differently because of those physiological reactions. Some people really don't like feeling that way. Some people do. Some people like to be scared, right? People that like to be scared, ride roller coasters. They watch scary movies. Some people cannot stand scary movies because they don't like the being scared. They're more sensitive to those sensations associated with anxiety. They have higher anxiety sensitivity. So if we present a neutral stimulus that naturally elicits fear, or anxious, I'm sorry. So we show some people, we put them in a room and we put a bear in the room with them that will scare them. It's going to be a more intense fear for people who have higher anxiety sensitivity, who are afraid of being afraid. It seems that people that are afraid of being afraid or uncomfortable with being afraid are more likely to develop phobias. But we say seems because there hasn't been a prospective study yet where you measure anxiety sensitivity first before somebody has a phobia and then see, okay, later on, do they develop phobias? What we know is that people with phobias have higher anxiety sensitivity. So the question here is chicken or the egg? Which came first? So did they have anxiety sensitivity, which put them at risk for developing a phobia? Or do people who have phobias then develop higher anxiety sensitivity because they more often experience high levels of fear and anxiety? Another thing to think about, the idea of prepared learning, that some stimuli are easier to learn to be afraid of. Right? If we're trying to classically condition somebody to be afraid of something, some things easier than others. It's easier to make somebody afraid of a snake than it is to make them afraid of a gun. Right? So I show you a picture of a snake, we pop a balloon. We show you a picture of a gun, we pop a balloon. We do that a bunch of times. We show you the picture of the snake, more likely to have this kind of startle response, some sort of fear response, than if we show you a gun. Both arguably equally deadly. Why would it be easier to learn to be afraid of a snake than learn to be afraid of a gun? Well, according to this idea called prepared learning, we're biologically prepared to be afraid of certain things. And again, the idea being that, and that certainly is true. It is easier to be afraid of some things than others. The explanation for why that is, we don't know if it's true or not, but what's generally thought is that this is the result of evolutionary mechanisms. That our ancestors didn't have to deal with guns. When I talk about ancestors, I'm talking about going back millennia, because evolution works slowly. So we're talking about natural selection. So a long time ago, there were no guns to be afraid of, but there were snakes. Right? There was dark. There was heights. And so the people that were afraid of these things that were present in their environment before lived. Those that weren't afraid of these things may not have lived. Fallen off a cliff, gotten bit by a snake, eaten by a bear, whatever. So, and there may be people that were afraid of them. Maybe there's something genetic related to their reaction to those creatures or instances, and then those things get passed on down to us. So we inherit a predisposition to be afraid of certain things. Okay. So that's the idea of prepared learning. And again, generally classical conditioning is used to explain the acquisition of phobias, but there could be other paths to acquisition, right? Which you could still pull from learning theory, thinking about modeling, and this is observational learning, where people learn to be afraid because they see other people being afraid. And we certainly have seen this in terms of studies documenting that if parents show fear of certain things and their kids see that, they're more likely to show fear of that same object or situation. Right? So some modeling may be involved in the development of phobias, and also potentially informational transmission. And this is where maybe they don't see their parents be afraid because the parents are avoiding whatever it is, but the parents talk about how scary something is. Snakes are dangerous. Never touch a snake. Never pet a snake. Never get near a snake. They're so scary. They're bad. They're bad. They're bad. Tell a kid that enough. It's informational transmission. going to be transmitting the phobia by telling them how scary something is and building the idea that it's scary, even if they don't see you be afraid of it or have a chance to experience it themselves. But these things seem to play a role, but there's stronger evidence for classical conditioning to play a role for more people. Now, in terms of the maintenance of phobias, still looking at conditioning, but now talking about operant conditioning. Right? Remember, operant conditioning is all about consequences of a behavior making a behavior more likely or less likely. If a consequence of a behavior makes it more likely, and we're talking about reward and reinforcement, if the consequence, we're talking about reinforcement, not necessarily reward. Positive reinforcement is reward. We take away something good to make a behavior occur. We take away something bad to make a behavior happen more often. That's negative reinforcement. And then punishment, right? Presenting an aversive stimulus, taking away an aversive stimulus, positive and negative punishment to decrease the behavior. That's operant conditioning, right? And the idea here is that the phobia is maintained by operant conditioning because avoidance is rewarded. Because what happens with classical conditioning, if you think about ringing the bell, getting the dog to salivate? Well, we got this great conditioned response, but you keep doing that. You keep ringing the bell, they salivate, ring the bell, salivate, ring the bell, salivate, and you don't ever present the meat powder again. Eventually, you ring the bell, dog's not going to salivate. Right? What happened? Extinction, right? The stimulus-response connection was extinguished, became extinct. The conditioned stimulus no longer elicits a conditioned response because, again, before it was a signal that this thing was coming, and that signal is no longer accurate. The brain figures out, okay, ignore that information now, it's no longer relevant. Okay? And so if you become afraid of dogs because a dog bit you, and then you repeatedly interact with dogs and no dog ever bites you again, you would stop being afraid of them. All right? That's the idea, that you would experience extinction in terms of that stimulus-response connection. Why don't you experience extinction? Well, if you have a phobia, what do we know about phobias? They avoid the phobic stimulus. I start getting close to a dog, I think it's around the corner, I go the other way. Right? So I start getting anxious, getting anxious, feeling bad. I avoid the phobic stimulus. I feel better, right? And if my anxiety, I can think of it as an aversive thing. I remove that aversive stimulus, which is my anxiety. And if I remove something aversive, it makes my behavior more likely to go up. So my behavior here is avoidance. My avoidance is going to increase because I felt better. I took away the bad feeling, right? And taking away the bad feeling to increase behavior is negative reinforcement. So avoidance is negatively reinforced. And because it's negatively reinforced, you never get a chance to be near the dog. And if you're near the dog enough, you have extinction. But since you don't, since your avoidance is negatively reinforced, you never experience extinction. Okay. In terms of the expectancy of danger, another view here is that people's expectancies about fear-provoking stimuli may play a role in the maintenance of phobias. It could be that when people confront or nearly confront the phobic stimulus, right? So they get close to the dog, they're about to see the dog, and then they get afraid. Right? Their experiences are confirmed. Oh yeah, I saw that dog, I started to freak out. Dogs are scary, right? This confirmation or strengthening of expectancies could be what drives avoidance. And again, we're still talking about prevention of extinction. So you can't have extinction because you're avoiding. So either you're avoiding because you feel better for avoiding, which is operant conditioning, or you're strengthening your expectancy of danger. That, oh yeah, I did feel scary. Whew, good thing I got away. That is scary, and it's clearly scary because I was scared, right? Which is kind of circular logic, but it may work for some people. Another thought is when we talk about fear structures, right? There might also be fear-related schema, and schema are just cognitive structures. You can think about building in your mind to hang ideas on. So we think about these fear-related schema that involve relationships between stimuli and responses. These structures influence how information is interpreted and stored related to the feared stimuli. So if some initial fear experience leads to the development of a schema, then it may be that using that schema seems helpful, and so you then will select information that's consistent with your schema to be assimilated, and you won't accommodate your schema. If you remember your language from learning about Piaget. So if you think dogs are scary, you'll once you develop that schema in the first place, you'll selectively look for information confirming that dogs are scary, and you'll ignore information that may indicate dogs aren't scary. Right? So you think of it in terms of a very kind of behavioral point of view, or you can think of it from kind of a cognitive point of view. Either way can be used to try to understand how phobias are maintained and why, without any kind of purposeful intervention, they may persist for quite a while. Okay, there are also biological contributions to think about when we talk about the etiology of phobias, and even more generally, anxiety disorders. One thing is the idea about there being two circuits for the processing information related to anxiety. A fast circuit and a slow circuit. Two separate neural pathways involved in our experience of fear. And both begin with the station in the brain, which is the thalamus, right? Signals come to the station, come to the thalamus from sensory messages, right? All except for smell. So what you see and what you hear, what you feel, those data come in and are routed to the thalamus first. In the fast circuit, some of the messages come to the thalamus and go to the amygdala. In the slow circuit, they come to the thalamus and then go to the cortex, right, which is your kind of higher order thinking area of the brain. The amygdala being more a primitive area of the brain, lower down, more central. In the fast pathway is your primal pathway, where you have basic messages about this is dangerous, this is not dangerous. The slow pathway involves more elaborate processing, where you're going to be relating sensory information to previous experience. Okay, here's this thing. It's kind of it may be scary. What do I know about this? Oh yeah, that there's this person walking toward me. Oh yeah, that's my friend. I recognize their face. Right? You're comparing the incoming and sensory data to memories, expectations, logic, all that stuff. That's going slower. Right? In that we have these two circuits explains why sometimes you may have this initial fear reaction, like, oh, something startles you, and then a beat or two later, oh, no, everything's fine, and the fear goes away, right? Because it was processed at that fast circuit, your body got ready for fight or flight, oh, scary stuff's coming, but then the information kept getting processed a little further down the line in the cortex, and everything was copacetic in and the cortex sends messages to turn the body's fear responders off. Everything's cool, relax. Right? So in terms of the fast circuit going through the amygdala plays a central role in the experience of fear, and not surprisingly, also rage. Right? Rage is very biologically very closely related to fear. When people get really upset and really angry, it seems to be related to being afraid of something coming for you, afraid of losing something, what have you. And the amygdala is also involved in the formation of emotionally charged memories. Right? And again, memories being up in the kind of the cortex, but emotional memories, the amygdala is going to be firing when those memories are being encoded, which will have an impact on how those memories are encoded and stored, and later being able to be retrieved. Right? Which is one reason sometimes you'll find that memories that are stored when you're feeling a certain emotion are easier to recall when you're experiencing that same emotion again later. The amygdala needs to be firing again. Right? And sometimes when the amygdala is really going at it, it may disrupt the encoding of memories. Right? They may not be stored like other memories are, and they may be harder to make sense of and harder to remember certain things that are very emotional. Obviously, neurotransmitter pathways also play a role, and it's several important neurotransmitters related to experience of fear. Glutamate, serotonin, GABA, dopamine. GABA is probably the one you hear about the most when it comes to anxiety. but it's not the only neurotransmitter that's important. Whenever you experience fear, all those different neurotransmitters are going to be playing a different role. Genetics, also important. Fearfulness in general seems to have a strong genetic component. And there, if we try to look at heritability estimates, which are one indicator of genetic influence, heritability estimates are higher for fearfulness in general than they are for phobias in particular. So if we look at, well, how likely is it if someone has a phobia, if somebody else in their family also has a phobia? There's some of that, but if we look at, okay, are they kind of above average in fearfulness? How likely is it that somebody else, first degree relative, is also above average in fearfulness? Yeah, pretty likely. Because so being fearful, kind of a tendency to be anxious, which may be related to anxiety sensitivity, seems to have a strong genetic component. But having meeting criteria for a phobia takes some other stuff going on as well. Right, so that's where some of the experience probably comes in. Okay. Moving on to social phobia. This is about performance anxiety, right? This is a marked, persistent, same words again, DSM is very redundant, a marked and persistent fear of one or more social or performance situations in which the person is exposed to unfamiliar people or to possible scrutiny by others. The person fears they will embarrass themselves. Right? So either people you don't know are going to be there, or they're going to be possibly scrutinizing, watching you, and judging you. And the fear is that you're going to do something embarrassing, and you're going to embarrass yourself in front of others. And we often think of social phobia, be afraid of being around people, and not really, unless it's a fear of being around people because you're afraid that you're going to do something embarrassing. And the instance of social phobia that we see that people maybe don't think about are the more performance-related ones, like sometimes in baseball the catcher will get the yips, where they make a routine throw back to the pitcher. They've done it a million times, and then maybe once they screw it up or something, and then they get in their head thinking about it, and they have this fear of that they're going to throw it to the pitcher and it's not going to make it. They're going to overthrow him, and so they can't do it because they have this fear of doing this embarrassing thing in this one specific performance situation, and that would be a social phobia. So that happens. It's something maybe you don't think about when you think of what a social phobia is, but it certainly could be that. Also, speaking in public speaking is probably one of the more common social phobias. And again, it's the fear of doing something embarrassing when people are looking. Right? It's not just the fear of doing it. Like if nobody's there, there's no fear. It's all about the audience, other people seeing you and being embarrassed. So, similar to what we see with specific phobia, exposure to the feared social situation almost always provokes anxiety. The person recognizes the fear is excessive and unreasonable. So again, it's in the same language we just saw with specific phobia. And the feared situation or situations are avoided or endured with intense distress. So same kind of thing with specific phobia. It's just instead of being afraid of an object or just a situation, this is a particular type of situation, a situation where you may do something embarrassing. It's not just, again, it's not just being in public, it's where you're going to be called upon to do something, to perform, or to socialize, and you're worried that you are going to do something embarrassing. People are going to judge you negatively. The avoidance or anxious anticipation or distress interferes with functioning, or there's marked distress about having a phobia. So again, either it gets in your way, or you just wish that you didn't feel that way. If it's a youth, individual under 18, duration of at least 6 months. Symptoms not better accounted for by substance, general medical condition, or another disorder. So if you're worried about embarrassing yourself because you're drunk, then you probably shouldn't be worried about embarrassing yourself. And so it's kind of this temporary thing, and that worry will go away once you're not intoxicated. So it's kind of substance specific, not a disorder. You're just intoxicated, or possibly intoxicated, at least under the influence. General medical condition is the DSM term for any kind of medical disease or illness, really, that might explain it. So, if you have somebody that's undergoing chemotherapy and they have cancer and their hair's falling out and they're embarrassed about their not having hair, that's not really social phobia, right? That's kind of related to this general medical condition. Or if there's another disorder, if they have panic disorder, where these unexpected, uncued panic attacks, out of the blue they have panic and they're afraid that they're going to have a panic attack in public and that will be embarrassing, well, that's panic disorder. That's not social phobia, so you don't diagnose that twice. Or people with body dysmorphic disorder that are kind of preoccupied with a real or perceived defect in their appearance. Like they think, oh, my ears are so big, and I can't go out in public because everybody will laugh at my ears. Okay, well, that's better explained by body dysmorphic disorder. It's kind of more specific, right? So it's a better explanation. You don't diagnose both. It's better accounted for by that disorder, not this one. And then last, if a general medical condition or other disorder are present, so you could have, another disorder or a general medical condition, but the fear is not related to it. Okay. If you have a food allergy and are afraid of eating peanuts, people will laugh at me if I eat peanuts, my face blows up. Well, yeah, they would, because you would. That's not a phobia. That's explained by the medical condition. But if you have, say you have cancer and you're undergoing chemo and your hair falls out, and you're worried about speaking in public, not because you don't have any hair, but because you think you'll say something stupid or silly and people will all laugh at you, then yeah, it could still be social phobia, even though you have this other medical condition, general medical condition, that may at least a little bit contribute to your fear. If it doesn't fully explain it, it might still meet criteria for a mental disorder. Okay, the experience of social phobias, look at onset and prevalence. As I said before, social phobia onset's usually around adolescence or adulthood when people are diagnosed, but quite frequently people that are diagnosed with it report shyness in childhood and kind of get that history. They kind of talk about always being a shy person. So it seems like people maybe kind of born or early on develop a sensitivity to being evaluated by others, and a shyness that may reach kind of pathological levels in adolescence or adulthood. Okay. Lifetime prevalence, again, is 12%. In terms of comorbidity, about half of people that are diagnosed with social phobia are also diagnosed with another disorder at some time in their lives. So pretty high rates of comorbidity there. Typically, it's another anxiety disorder or a mood disorder. Sometimes a substance use disorder, which you could think may be related to dealing with their anxiety. And for these things, social phobia typically comes first. So think about how social phobia might precede major depressive disorder. Why would being anxious about being observed by others and embarrassing yourself lead to depression? Well, if you're avoiding speaking to people, going to parties where people are going to evaluate you, you're going to avoid trying things that you think are going to be embarrassing, it might lead to some social withdrawal, some loneliness. As we get more isolated, the risk for depression goes up. Right? Panic attacks can occur in people with social phobia. So if somebody has a social phobia related to public speaking and they try to speak in public, or they're about to go on and they have a panic attack, then that's still just social phobia. They certainly can have panic attacks. Doesn't mean they have panic disorder. Because again, in that instance, the panic attack is cued by their kind of phobic stimulus, which is this performance situation. So can have panic attacks. In terms of the relation to normal anxiety, well, I'm shy. I don't like talking in front of people. Yeah, it seems to occur on a continuum. But people that meet criteria for social phobia seem to be different, because they are shy people, but it isn't just shyness, right? The key feature here is this idea of the fear of negative evaluation. It's not just kind of a vague discomfort being in situations. It's really this worry and kind of higher level emotion of fear that it's not going to go well and they're going to laugh and I'm going to be embarrassed. And really where the fear keeps them from doing it. And if you can push past it and do it, and once you start talking, oh, it's not so bad, then that's not social phobia. If you push past it, oh, and yes, it's horrible, and it's horrible the whole time, well, then you're enduring it with marked distress, and yeah, it's still social phobia. There is social phobia generalized type. You can add the specifier. And this you add if the fears include most social situations. So if it's just speaking in public or it's just giving presentations in class, that's it. That might just be social phobia if it then interferes with your functioning. But if it's speaking in public, it's going to parties, it's drawing on a chalkboard in front of people, if it's all these different things, then it's social phobia generalized type, which is when we talked about personality disorders later, we'll see that social phobia generalized type is virtually indistinguishable from avoidant personality disorder, which is characterized by a persistent fear of negative evaluation by others. Okay. The etiology of social phobia, similar to specific phobia, probably from a kind of psychological contribution, learning experiences playing a role. Having a negative experience in a performance situation. It didn't used to scare you, and then something bad happened, and then that performance situation gets associated with the anxiety experience at one point in time, becomes a cue for it. It's kind of classical conditioning, and then the avoidance again is operantly reinforced via operant conditioning. You may also have some modeling by seeing somebody else be afraid of certain situations, or talking about how everybody's going to watch you, they're going to judge you. Or everybody's going to watch me, everybody's going to judge me. And if you see them saying, if you listen to them saying that, and then you internalize it as your own, that might contribute to it. Also, same kind of things we talked about before in terms of biological vulnerability with that anxiety sensitivity and genetics. All the same things for specific phobia apply here to social phobia. And then one other thing that didn't talk about specific phobia that may contribute to the risk for developing such phobia, interestingly, is poor social skills. And again, this actually kind of goes back to the learning experiences, because if you have kind of negative social interactions where they're not rewarding and people do laugh at you, right, that may lead to, wow, now I'm going to be worried about it. Well, when are people going to laugh at you? Well, they may laugh at you if you really have poor social skills, undeveloped social skills. That might put you at risk for these aversive situations, which could then put you at risk to develop the phobia. Okay, so that makes sense.